names to put on the rolls. So you're right, Dr. Joe. There's for folks that have got some serious health issues that really need to be at the oral surgeon's office. We've got a dilemma on getting folks in, and on the MCOs, if you all have any ideas on how to handle these situations, that the floor is open to you here in a minute, just to, because we do have people out here. I had one in here this morning already that, severe heart problems, angina, free bleeder, active heart disease that I don't need to be pulling out root stubs, here with those health conditions. And so sometimes we have to refer them to the oral surgeon, but it's taking months to get them seen. Joe, you got any other comments on that? Or are we good to go ahead?
Yeah, I think go ahead, Phil.
Yeah, I've got a comment. I mean, the number of providers is up slightly, but we know that every provider is not delivering the same level of care. A provider that sees, 6 or 10 patients a month is, yes, they count as a provider, but it'd be interesting to have some sort of data on, encounters, paid claims, somehow or another, just to see, what activity level these people are, and, maybe have some sort of cutoff, whether that's, 50 procedures a month, 100 procedures a month, where some sort of reasonable cutoff where we can see that, who's actively seeing Medicaid patients out there. It'd be interesting to see if we had that data with some sort of cutoff, some reasonable cutoff, where you're actively seeing Medicaid patients, as opposed to somebody who's just seeing just a handful of them. Just be interesting to see that.
Dr. Phil, I think what we had done, and this, I can't remember, you can correct me if I'm wrong, but a few years ago, it might have been just before you got on the TAC, we were able to do a kind of an analysis of each providing dentist. We did it by paid claims. And
Dr. Bobrowski.
And then we put everybody into kind of categories of paid claims, like 0 to 5,000, 5,000 to 10,000, or whatever we came up with. And that gave us, it seemed like a pretty good idea of, well, how many are actually doing the work out there. There may be plenty on the rolls, but it's like, well, how much work's actually getting done? That was one method that we used. I'm sure there's probably better analytical methods that we can look at if anybody's got an idea that would maybe be better than using paid claims as a guideline.
Dr. Bobrowski, this is Nicole with Avisis, and you're 100%
Yes.
correct. When we provided the reporting information by MCO, when we used to do our presentations, one of the slides that was in that presentation deck was it identified the number of providers within the quarter that billed and that were paid more than $500. And then we did the 500, 1,000, and then 5,000 or more. So the providers were divvied out into those three categories.
Is that in terms of IT for you all, was that relatively not too burdensome to do that method?
From Avisis's perspective, yes, that's something definitely that we can release, but it's my understanding that DMS requested that all reporting requests go through DMS. So if I remember correctly, the Dental TAC committee did request that information of DMS.
That's correct, Nicole. This is Jean from Anthem. That is, it was something we reported every time we had a TAC meeting, but we were asked to stop and for you all to go through the other channel. Yeah.
So we could, the TAC, then today, we could make that request to DMS to go back to that number of providers that were paid more than 500. And was that per quarter, Ms.
Yes.
Nicole?
Yes, it was per quarter.
Yes, it was.
Yeah, and to give you some insight as to, I think the lift, kind of as Nicole mentioned, I know like on the DentaQuest side, all of that analytics is already developed, and we have that, basically the queries are, and that logic is all saved. So it's something that can be easily replicated and just reported on an ongoing basis if we need to revert back to that.
Garth, I think that's something that it'd be good to know on a quarterly basis.
Well, I agree. And you know, the other thing, and I know the MCOs have this data, but on terms of by location or region of the state, would that help anybody or anything in terms of, well, we need to get some Medicaid providers down here in these 3 counties, or we got to get some Medicaid providers over there on the other side of the state. Would that be of any benefit to add in some method of the location of where these? I don't need we don't need the name of the provider. We just need the kind of the locale. Would that help anything?
Garth, I think they had that split up one time in regions, if I remember correctly. So it was large multi-county, so it gave you less of an ability to identify an individual provider because they were grouping counties together. I think I remember that.
Dr. Bobrowski, this is Nicole again with Avisis, and probably DMS can speak to this better than I can, but as I understand it, on the Kentucky DMS website, they do release a report that identifies the providers by county with accounts, and then it compares it to DMS fee-for-service by MCO. So that information is available.
Nicole, are you aware? I'm sorry, Garth. Are these numbers by license number or by location? The reason I ask is there are a number of providers that are in multiple locations. I want to understand well if it is what we're looking at here.
Yes, and actually you bring up a really, really good point. Last year, DMS required that we change our criteria that we're using to identify the providers. Now we have to report the providers based upon their full-time location. And a full-time location is defined as 16 hours or more at an office. So our large group practices that used to report all of their providers at all of their offices, we no longer can report them that way for our geo-access reports. Now we can only report a provider that is 16 hours or more at a practice. So the numbers that we're actually providing today in terms of Avisis, the numbers that we're providing today are different than they were in 2015, because in 2015, we were able to count the providers at all of their locations. Does that answer your question? I'm sorry.
It did. Thank you. It certainly will skew the comparison, but it did.
Great. So for the Avisis numbers, we did do basically both. We looked at our numbers from 2015 and then used the same criteria that was used to count the providers in 2015 to 2021. As you know, we are servicing or we are contracted with 4 of the MCOs in Kentucky. And our first client in Kentucky that we had in 2000 at the time of the count for 2015, compared to today, again, using the same criteria, the network increased by 6%. Our other MCOs that we brought on, the network has increased by 30% for those. However, those increases were, number one, because one of the MCOs went from just urban areas and they went statewide. So when they went statewide, we had to do, open up the recruitment. So that was the reason for that. And then the other MCOs, we were able to increase their networks to what our first client from what they originally were before they were a VSIS. So overall, to look at the overall increase, it is about 6%.
I think those are important points. It's certainly important to look at the overall scheme of it too. And these are big, heady questions, but it's not solely just the number of individuals. I mean, if you look just at the number of individuals, it's my quick and dirty math, and Phil's help with the 23% increase. We have a 23% increase in patients. Endodontics, we have 33% more providers. Perio is no change. Pros is no change. Orthodontics, we have a 1.5% increase. Path is a 14% increase. Pedo is a 10% increase. And oral surgery is a 29% decrease in providers. That's scary. But then when we factor in urban versus rural, I think that's another clear point. And we always bring up the oral surgeons and their locations because a lot of the rural areas are still underserved. Pediatric dentists, the rural regions are underserved. Orthodontics, the rural regions are underserved. And I think if we had a breakdown of the GPs, we would see an increase, but I would wonder how much of that percent increase in the GPs is more urban and what impact that has on the whole. Are we gaining 23%, but are we gaining 23% on the rolls in areas which are even less served than what we're seeing with these numbers that frankly are quite concerning?
So this is Veronica with Medicaid. I just want to clarify one point about the Medicaid enrollment numbers. That includes a large enrollment related to our presumptive eligibility, which, as we all know, is temporary and was expanded and has been expanded under the pandemic. So that's not an ongoing, enrollment increase. That increase now, as of July 1, they are allowed 2 PE periods of a max of 2 months, so a total of 4 months. So, I mean, it skews, and that's about 123,000 people. So it skews the numbers a little bit. So I want to just make sure you all are kind of filtering your evaluation and understanding that right now, that number that was presented for the end of 2021 included our presumptive eligibility.
And this is Nicole again. Dr. Petrie, not to make the situation worse, but I think it is also important to discuss the impact of COVID. With COVID-19, dental offices, I think, were probably the most impacted by COVID-19 because you guys are right there in the mouth and are subjected to exposure. So that has caused offices to close longer and more often than other specialties. In addition to that, because of COVID and because of the exposure, you had to increase your sanitation, you had to change your waiting hours, which in turn decreased the number of patients that can be seen in a day. So the number of patients that you treated prior to COVID compared to the number of patients that you're treating today is less. So that means that's less chair time that you're able to have patients in for. And so that increases, unfortunately, the time wait for patients to get into a new office or get into an office as a new patient. And then on top of that, we also have the pent-up demand for those 16, 18 months that everybody was shut down for COVID. We were not able, you were not able to do the routine cleanings. You weren't able to do the restorative services that you could put off because they weren't emergencies. And now everybody is in the position where you're trying to get everybody caught up. And you're going to treat those existing patients and emergencies first. And then the new patients are going to be put more so to a future appointment or moved out. In Kentucky, we had great access to care rates before COVID. I mean, when we did our surveys, 98% of our providers, were responding that they got people in less than the amount of time that DMS required. Now it is the opposite. Everybody is doing their very best to get patients in as quickly as they can. They develop creative ways to try to accommodate that by creating patient lists. And if a patient cancels or doesn't show, they have a list of patients that they can call in that are trying to get in to try to fill those appointments and meet the patient's needs. So I think our dental offices are doing everything they can to try to treat the patients, but we have to be understanding that unfortunately, because of COVID, there are some situations that impact our oral health community that other specialties are not experiencing.
That's so true, and it's certainly, in discussions with the pediatric dentists that we deal a lot with, they're treading water just trying to get back on cleanings schedules, let alone the emergent care that has to be done right now. And so, I mean, COVID is clearly going to impact everything that we do, but and it's going to take a while until we catch up. We may never, in some cases, catch up, but that is an extremely valid point, and that goes back to utilization more than it does simply numbers of providers versus numbers of recipients.
Right.
Just for accuracy, when we back out that 100 and some thousand that we were talking about COVID, it puts about 18% increase.
Which is scary with a 30% decrease in oral surgeons.
Yes.
So one of the questions asked was, what are we doing to try to increase access to care? I will say one of the first things that we did was to address the Dental TAC Committee's request for increased fees for certain procedure codes. So all of the Avisus administrated MCOs reviewed those requests and implemented those, actually a little more than what was requested, and did, and also addition for the oral surgeons. Just because we're in a public forum and proprietary information, I can't go into the details of those. However, we are doing our best to meet the needs or the request of the oral health community in Kentucky. We're also looking at different things that we can do from a referral perspective to ensure that patients are receiving or patients are referred to providers that are in true need for those services, so that as oral surgeons are treating patients, they're actually treating true cases that need to be at an oral surgeon and not a general dentist, so that we can make sure we're getting the best time out of the oral surgeon's chair. That's something that we're looking at. We do it in West Virginia for a provider in West Virginia, but we're looking at that across the network also. So we have a number of things that we are doing to try to work with the offices to help those areas where there is a struggle. In addition to that, I apologize, I have to take my glasses off because I can't see with my glasses on. So the increased fee schedules, the providing access when we have situations, especially the emergency cases where an adult or a child needs to get into a practice, but for reasons A, B, or C, our customer service team can't find a provider for the member. We do have our provider relations representatives that get involved. Of course, they have close relationships with our provider community. And then in some situations, we have to rely on Dr. Cotto's relationships with providers. Thus far, we've been able to coordinate all of those emergency or urgent services without a complaint going to the state for access to care. So access to care cases for those elevated ones, although we have difficult situations for our oral health providers in Kentucky, we are able to rely on relationships and partnerships with practices to ensure that our Aetna, Humana, Molina Passport, and WellCare members are seen.
Garth, if you're on your phone, hit the bottom of the screen, and you should be able to unmute yourself of your phone screen in the bottom left corner. It'll pop up. Sorry.
We lost the boss.
Maybe I shouldn't have told him to touch his phone. Sorry, guys.
Might have hung up.
He'll call back in.
Okay, now, can you hear me now?
Yes.
There we go.
I don't know. I tried that, Joe, a few minutes ago to hit that button on the left, and that it showed that it was unmuted, but then I get a message over my phone that my phone has been muted. So,
Garth, I muted it for just because when Nicole was speaking, there was some background noise, and I'm sorry I didn't come back and unmute you quick enough.
okay, all right. Well, thank you.
Charlie shut you down.
Heard enough of you, Garth.
Y'all, I don't, do I have video? I mean, can y'all see my face?
Not yet.
I think it was on there a while ago. It's getting so old and ugly that
No.
I don't blame you for unmuting and unvideoing it. So,
Now, I didn't do anything to your video. I just did it to your phone just hit mute on your phone because it was crackling or something.
you know, I'm in a perfectly quiet room, so I don't know where the background noise is coming from. It may be some static from, I don't know.
Well, I'm not hearing it now, so who knows?
Okay. Very good. We'll get through this one way or another. Okay, and I didn't mean to. Was given a report, and I hope I didn't cut somebody off.
No, this was Nicole. Dr. Cottle, was there anything else that you wanted to add or anything that I missed?
Other than the increased costs that providers are also facing as a headwind, as relayed by numerous small offices and group practices. I know the oral surgeons are having their registered nurses being stolen by hospitals, paying outrageous recruiting signing bonuses and salaries. I know of one oral surgery group that lost 2 registered nurses, and these are critical staff that start IV sedations, that monitor recovery, who assist in the medical diagnosis of the patient. So they're facing those headwinds. I've had another group practice say that, and some of the numbers I've read for Kentucky are that the unemployment rate for dental assistants is like around 1% in Kentucky, and pretty much any dental assistant that wants a job has a job, and they're jumping ship and demanding huge salaries. One provider group told me they had paid up to $32 an hour for a chairside assistant, which was a couple of years ago, that was a dental hygienist. So they're facing huge cost increase. A box of gloves that used to be $30 and now, $3 and now $30 a box. Huge cost headwinds that they're facing. So that's just more of the COVID result that we're facing here.
Well, this as a rural provider, I just want to give you all a big thank you for listening and for looking at the fee structure. And I know we can't go into a lot of details, but I do appreciate and recognize that you all are aware of these increased in costs that the dental providers are facing, and I just appreciate it and thank you from the bottom of my heart, and from the other providers. I'll speak for them too. That I know that they are very appreciative of those efforts. So thank you all very much.
Dr. Bobrowski, this is Nicole again. One other thing we wanted to ask, and this is kind of outside of the box. thinking, and also to share what other states are doing. As you know, I'm located in Maryland and worked very closely with the Maryland Medicaid program. And one of the things that Maryland does, and I think Kentucky does this also, but I'm just not sure if it's done on the same scale. And that is in Maryland, it's called the Mission of Mercy. And that's where the oral health providers get together with the Mission of Mercy and coordinate oral health days where they do extractions, restorations, even some of them will offer denture repair services. It does really help with helping with getting caught up in that pent-up demand, Dr. Petrie, that you mentioned earlier, and then also ensuring that the locations for the missions are in rural areas, because a lot of times those are the members that can't even get into the urban areas to receive services where there may be more available appointments than there are in the rural areas. But just wanted to kind of throw that out there and see if that is something that is being considered or something that could be considered.
I will add to that, Nicole, that just recently down in the Harlan area, we did a RAM clinic, which is like a Missions of Mercy clinic, a mom's clinic. And Avisa's was, one of the major suppliers of funding for that RAM clinic. And so we do that on a routine basis. But Missions of Mercy, I also did those when I was in North Carolina and helped organize those there. So that's certainly an avenue that I think maybe all of us can look at across the state.
Right, and this is Dr. Bobrowski. I have heard of and know a little bit about Mission of Mercy, and I am aware of the RAM clinics that sometimes they've been in Eastern Kentucky. I think there was one a little while back in the western part of the state, but I think they quit. Was it just before COVID hit? Maybe 2017, 2018 might have been the last RAM clinic, but then did they do one?
Yeah, we just did one about a month and a half ago down in the Harlan area. The one last year was canceled because of the COVID spike. So no one was going to put one on during that, but we did do one about 6 weeks ago.
Hey, Jerry, how was the turnout at that one?
It was very good, more than year before last.
Yeah, because I know, I was involved in those back in 2017, 18. And when the governor expanded, Medicaid coverage for adults, I mean, the last RAM clinic, I mean, we wrapped up in one day and packed up, went home. There just wasn't that many people, there because they had some coverage. They didn't want to, stand in line. But I'm glad they had a good turnout.
I know one of the things we found successful in Maryland is the prep work for the mission. So if that initial screening is done in a practice or set up a clinic day just for those initial screenings, and that way the patients don't have those long wait periods, they can just go in and the dentist can start and have them in the chair. They don't have to go through that pre-screening. You see more patients, and then the patients that hear about it at the last minute, those are the ones, that have to wait, while the ones that did the pre-screening are able to get through. So they have found some ways to help the clinics be more attractive for people, so that they're not there, all day long, or they don't get there at 5 o'clock in the morning and they're not treated until 3 o'clock in the afternoon. That's some of the things that I've experienced in working with them at the University of Maryland. So maybe that's something we could partner with in the future.
Right. And I think, like Dr. Cottle said, that when the next RAM clinic becomes available, I think we can, and I hate to say this, I don't know, but if we could get the information ahead of time out to the Kentucky Dental Association, they can help to advertise that in areas and and even help to notify dentists in that area for their possible services. And like you said, maybe even be open up their office at least to do the initial prep, work of the exam, and then like to say that would help maybe to shorten the lines when they get to the RAM clinic itself. But when we find out the dates of the next one, let's help advertise that and see if we can get a good number of dentists, dental hygienists, and dental assistants to participate. Okay. Now, Ms. Nicole, I know you were speaking for Avisis. Did you need to break down anything on any of the MCOs that you all represent, or are you good?
No, we're good. We're good. We decided to give the network information at the overall level, that the network since 2015 today, when you compare the numbers or compare the counts for how they were counted in 2015, the network has increased to about a little over 6% for the increase in the network.
Okay, good. Okay. DentaQuest, you want to give a report?
Yes, of course, absolutely. Good afternoon, everyone. I hope everyone is doing well. So for DentaQuest, as you all know, our administration started, around that time, when we're looking at this comparison. And from 2015 to 2021, our overall or unique providers, I figured it would tell a good story to kind of keep it at a belly button count level so that, we can really just compare apples to apples. We had an increase of unique providers of about 30%, my apologies, from December 2015 to June 2021. In 2015, our network consisted of about 25% dental subspecialists versus right now it being 40% dental subspecialists. So, much of that increase has been in the subspecialty area, a mix of those, oral surgeons, orthos, pediatric dentists. We have right now currently about 4,300 access points. Our member to provider ratios, considering the amount of lives that we administer benefits for, is trending about 1 to 70 for the general practitioners, and then about 1 to 240. That is, just average number, on the subspecialty level. So, overall, there's definitely been a significant increase on our end as it relates to recruitment and just, having a robust network for the membership that we serve. I kind of, agree 100% with Nicole and some of the challenges that I think everyone is experiencing right now, with the dental industry and COVID and just kind of that impact. It truly is just, the perfect storm where, you just have decreased provider capabilities due to staffing, cost, and all those complications. And then that influx of membership, number one, from the increased number of Medicaid enrollees, and then number two, just as people's, are getting back out to the community. All of that during, let's be honest, in the summer, which is always like the busiest time of year. Everyone's trying to get their kids in while kids are out of school. And so just historically, summer has always been the busiest season. And when you add all those other components at that same time, it's definitely a challenge. So for us, as we kind of, go through this and try to navigate the channels of, COVID and this kind of post-COVID world, and trying to kind of ensure that members have access to care, we do have a few different processes and kind of make sure that members are getting in where they need to get in, when they need to get in. We survey providers regularly to understand their capacities. We understand that that's ever changing due to their office staff and just kind of all the things we talked about. So that is an ongoing monthly survey where we just make try to maintain as most accurate information as we can as far as what dates are, what dates are they operating? What is the capacity? Are they treating new patients? Are they not? Just kind of understanding the mix of, the individual offices, and just making sure that that's as up to date as possible. And making sure that when we get, any type of feedback from members as they call in, right? If they are in pain, things like that, we have a team that's reaching out to the different offices, to try and ensure that they have an appointment available. And if they don't, we'll just continue to make sure we with an office that's available to meet their needs. Sometimes they might have a provider if they have, some special circumstances. We need to make sure that we, account for all of that. So ensuring that members are getting in during these times, definitely a lot of different processes in place on our end to, try and mitigate some of those challenges. If you want, kind of talking about just different things that we're doing to increase access to care, in addition, or enhancing the network, trying to make it as robust as possible for members. There's a lot of different things we do. We monitor the Medicaid registration very, very closely. We know that, I know it's not a lot, but as these providers are coming out of their dental school and finishing up their residency programs and signing up for Medicaid, we do want to make sure that we're engaging with them proactively. So that Medicaid registration file very, very closely. We actually receive it on a weekly basis. We also compare to some of our competitors out there in the market. We want to make sure if members are transitioning from one MCO to another, that they, there's that continuity of care and they don't have to, stop treatment or anything like that. And they can continue seeing their providers that they normally do, or that they have an established relationship with. So we just want to make sure that, we match as much as possible so that we can just, have the most favorable experience for both the member and the provider, from an office perspective. We don't need any, ton of adverse effects if your member just switching plans. We want to keep it as seamless as possible for everybody involved. The next thing we do is we do have commercial products that we administer for, and we do compare our network to that commercial network as much as possible. We don't auto enroll anybody into all of our products. We do, engage on a one-by-one basis, making sure that, they're comfortable with the requirements and regulations and the fee schedules and, all the components that are pertain to being part of the Medicaid network. So we do look at that, and we try to, recruit those commercial providers as much as we can. I think we're really happy to report that about 20% of our network is unique to just benefits providers that are not part of the other MCO networks. So I think that's shows in itself, some of those efforts have been successful in just trying to slowly transition providers from that commercial over to Medicaid. Sometimes it's slowly. We don't advertise them until they kind of get comfortable, and then we can, go ahead and refer more members out. So there's a lot of different components there, just ongoing review and analytics. We have, like I said, the dedicated staff that really take the time to understand what's going on from a member patient centered care perspective and make sure that they get what they need. And we track all of that so that we can just review the trends accordingly. We also keep track of those providers, as we were kind of talking about with the previous reporting. That's something that we're very interested in, right? We want to know, to y'all's point, just because a provider's on a list doesn't mean that they're seeing these members, doesn't mean that, we don't want anybody trying to call several different offices and not being able to get an appointment. So we do track the providers that have not seen members. We look at them regularly every month and just kind of compare trends. We call it participating providers, so those that are enrolled versus actually participating and seeing members. So we do look at that and, have specialized outreach to those, make sure that if there's anything going on in that particular practice, we know what barriers we might need to address, or what any, challenges they might be experiencing, so that we could, work with that office and try and get them back to seeing, patients on a regular basis as they would have been before. So those are kind of a combination of different things that we've done to kind of improve the access. Obviously there's just a lot of different challenges that we've all talked about with COVID. As it relates to the rates, we have always paid, pretty much very high rates, as well for oral surgeons. So, we've kind of prided ourselves in that perspective. And I think that's been another thing that's successful, just ensuring, and that providers are getting reimbursed fairly and adequately, given the times and all the added cost that they've received. Are there any questions? I know that was a lot of info.
It is a lot of information, but that's okay. Anything about the, the number of providers, the numbers we were talking about 2015 versus now? I don't know if that applies to you guys directly.
Yeah, so those numbers, and that's what I had mentioned before. We increased from 575 unique providers to 748. That was that belly button count. Those are actual individual lives. If they're treating at multiple locations, that's multiple access points, but we're looking at it as actual individuals, understanding that you can only stretch someone, so much. And out of that mix, in 2015, it was 25% dental subspecialist. In June 2021, we increased to 40% dental subspecialist. So although we had a 30% overall increase in unique individual providers, we also increased that ratio of specialists, and a specialist increased as well.
Okay, thank you.
Oh, you're welcome.
This is Dr. Garth. Can you hear me?
Yeah.
Okay. I'm getting those messages again of muting and unmuting, and I thought I was still muted, but at the beginning of your report, I don't have video today. I'm sorry. Can you give me your name?
Sure. This is Christina Medina from DentaQuest.
Yes. Okay. Good deal. Well, thank you very much for that informative report. Any other questions from TAC members?
No.
Hearing none, we'll go ahead and United Healthcare.
Hi, good afternoon. This is Dr. Adam Rich. So I'm going to try to address a few of your questions here, and we'll see where we go. But from an access to care issue, being kind of new in the market, we've done a few things to make care hopefully more available to our members and the members of and the population of Kentucky. We've tried to we have provided PPE for need-based and school-based clinics in rural areas, and as one way to just try to make sure that those clinics are still able to operate and PPE has been more difficult to acquire, especially when you're working with reduced funds or minimal funding. Additionally, we have a team, our social determinants of care team, work engage community partners in all areas of the state to educate and make awareness of the need for dentistry and the dental services that are available to our members and the importance of it for overall oral health. So we're trying to outreach and make sure that dental needs are not just that people's needs recognized and addressed. Additionally, our coordinated care team understands the importance of oral health care, and in doing so, we're incorporating dental in just as much as part of overall health for our maternal health and our behavioral health, our DSNP programs. That dental always recognized as part of overall oral health and dental needs assessed, and making sure that those needs are being assessed and treated when those members are identified. Additionally, we were to go along with education, we've had a lot of toothbrush and educational materials to health departments and schools. So we're really trying to get our members educated, know the importance of oral health and to seek dental treatment. From a network perspective, I can't really give any data from 2015 necessarily. I can say that we have a full our network is our general dentistry network is meeting all the requirements, and we do struggle with our specialists, as I think, just as we noticed, the number of specialists, everybody has challenges with specialists, but we continue to our networks are continuing to grow. Our recruitment team is expanding the dental network, and so we're bringing more providers on constantly. And to that, as some of the other MCOs have alluded, our member service team is dedicated to making sure that members receive and have access to dental care when they need it, or even routine care. And we're committed to that contract to get timely appointments for our members, and we're making that work, whether there's a network provider dentist available or not. The member is the focus. So if we can't provide a network, we will find a dentist to provide those dental services and make sure the member gets the treatment that's required. But I think that sums up most of what are there any questions for United Healthcare?
I had a question. You'd mentioned social determinants of health.
Yes.
Some efforts, in that direction. Can you tell me a little bit more about what you all are doing to, assess some of the other gaps that this patient population has to access to care?
Yeah. So we do nutrition programs and community centers. We and education, screening clinics, those type of things. But I'm not sure exactly how to. We look for housing. We have whatever the member needs. We try to figure that out. So I'm not exact. I can't give you a whole lot of in-depth information at this time. I apologize, but I'd be happy to give a more full report on that at a following meeting.
I mean, I have a big interest in social determinants of health as it impacts, total health care and dental care. So, any information you could share on what you guys are doing in that direction, I'd be interested.
I'd love to, and my team would love to present, because I've been wowed by the number of endeavors that the team is engaged in, and just meeting members and patients where they are and figuring out how to get them better treatment. So yeah, I would really like to bring them into this.
Yeah. Well, a lot of the historical issues that providers have had with Medicaid, whether it be no-shows or just different compliance levels. People struggle with transportation, and if somebody's struggling to try to figure out where their next meal is, their dental care, especially preventive care, is not always front and center. So I think it's a big impact on people's health to give them whatever support we can, with housing and food scarcity and mental health and those types of things. So I appreciate that.
Thank you.
Dr. Schuler, this is Nicole. We also have an innovative program on the social, the SODH. So if that opportunity presents, we can also share our information for that program.
Yeah, no, I mean, I appreciate that, Nicole. I mean, we're currently working, with Humana on a pilot project that Humana has going. So, I mean, it's very interesting, to kind of look at the whole package of, health and social issues to try to get these people into a better place. So,
Yeah, and Dr. Schiller Anthem could also do the same. So we could put some type of presentation just so that you kind of know what's happening overall.
Yeah,
that is honestly, I'm sort of like with Dr. Adams. I think you get kind of wowed with some of the things that we are doing to help, overall. So that would be something Anthem would also be able to do.
well, maybe at the next TAC, maybe just, 2 or 3 minutes a piece, just kind of highlight, some of what you guys are doing. I mean, I'd appreciate it.
This is Dr. Garth. Dr. Rich, thank you so much for your report. And one thing I've already done is the governor has already appointed me this last summer to be on the MAC. At one of our earlier meetings, I brought up something very similar. The MAC has, give or take, 15 different TACs on there, and I think there's a few more other parties that are that come and are to those meetings or our Zoom meetings. And I brought up the fact that through the Dental TAC that maybe we could help in that arena of overall total health, like you said, the social determinants of health, and try to get the populations that we serve, do what we can to help them. And I think through the ideas from this TAC or other TACs, if other TACs can present, ideas to the MAC that may actually help, DMS in their efforts. I think I've already got it started. I'll add that to the agenda for our next TAC meeting. Is for lack of a better term for right now, just social determinants of health and other ideas. So we can, I think it'd be good to maybe promote that, and I can definitely present that to the MAC. And even at the next MAC, which will happen before our next TAC meeting, I can mention that this TAC, along with the MCOs, is and working with DMS also, that we're looking at this and seeing what we can do as a group, to help folks in that arena. Any other questions or comments along those question lines?
Garth, I have a comment. So one of the programs, and we're just getting it started with Humana, and it's obviously it's kind of focused on Humana's participants with our offices, but one of the beginning stages is just to get data. So it's just asking some very simple, straightforward questions, because we're all busy. We don't have time to sit down with a 2-page questionnaire with every patient. So we're whittling it down to just, I think, like 3 questions. In regards to food scarcity, mental health, those types of things. And really, it's just at this point, it's a data building type of thing. How many people in these programs are suffering, from some of these other social determinants of health. So, I mean, I think there's some things we can do.
Okay. Thank you, Dr. Phil. All right, I'm going to move on to, I do have one question for Ms. Veronica. We were talking about the number of patient increase that was due to COVID. I think you mentioned that there was that those folks are allowed Medicaid access for 2 months for those 123,000 people. And then I thought I heard you say 4 months. Can you clarify that for me?
Sure, absolutely, because it is a little confusing, but it's important to note that on January 1, so starting in January, we had approximately 123,000 people enroll in presumptive eligibility. And they were permitted at the time to have a PE period at the time was 3 months. It's the date of enrollment, the month of enrollment plus 2 months. And they're allowed up to 2 PE periods. So if you add the numbers together, that gave them a total of 6 months of coverage. So anybody that enrolled in January, and we had a large number that were eligible to enroll in January, they came off the rolls starting July 1st. So the CMS changed the rules on July 1st, and now a person still has 2 PE periods that they're eligible for within the calendar year. So that's if you had 1 period, you can have another period, and then you've maxed out. They now, though, are only allowed for the month of enrollment plus 1 month. So a total of 2 months per PE period. So let's say somebody enrolled in presumptive eligibility in July. They get their first period would be July and August. They can opt in to have their second period during the calendar year. And that means they would then get September and October. So they would get technically from July to October. Does that help?
Okay, yeah. Yes, great. Yeah, thank you. That cleared it up.
You're welcome. And so it is, you know, the reason for the big influx in January is because last year when we expanded presumptive eligibility, people, you know, met their 2 PE periods. But then when the calendar year changed, they were able to come back on for another 2 PE periods. And so we had that, you know, initial coverage at the beginning. And I do want to emphasize the reason we expanded presumptive eligibility was primarily because we wanted to get coverage for hospital, for pharmacy, you know, for those services that are really needed for somebody that's facing COVID.
Okay, great. Yes, thank you. Before we move on to our old business, Ms. Veronica, do we need, as a TAC, do we specifically need to ask, or we could do it at this meeting, to request DMS for information on that, like we talked about before, number of providers, number of paid claims, or paid more than 500, 1,000, 5,000 per quarter, or is what you've got on the website adequate for us to look at? I saw that once on the website, but I go on there periodically, but I maybe overlooked it, but I can't find that sheet again that was on there, because it listed it almost, like you said, by county, and how much was spent there for Medicaid. I can't remember the exact breakdown, but I did see that on the site.
Yeah, I mean, you can just make the request from DMS on what information you need, and then we can go back and take a look and see if what we have publicly posted works for you, or you know, we can look at pulling a data request for you.
Okay. Well, at this time, and I'd like to, I guess, open the floor for a motion to ask DMS for more information, like they had before, by county, dollar amount that was spent. If it can be broken down by 500, 1,000, 5,000, like that was done in the past, that kind of helps us to just see, you know, where's the need. Even though you all may have your Your radius is built in. Some places are still quite a bit of need, and that would be per quarter as compared to what you may have on the website. So I'll need a motion to that effect from a TAC member. Or if you want to reword it better than I did, that'd be fine too.
Garth, I'll give it a shot.
Okay.
Yeah. So we'd like to make a request from DMS for county-specific provider data showing activity levels or gross payouts, or however you guys want to take a look at it, and then we'll take a look at what you bring back and see if that's adequate.
Would you mind
Second.
timing on that? Like when would you like to start and finish?
We'd like to have it for, oh, you mean as far as the time periods for the data?
The time frame, yeah.
Could we look at it on a quarterly basis? Like a rolling quarterly basis?
Okay, so do you want to start
January 1 this year.
Okay, there we go.
That work?
I want it. Thank you.
Yes, you're very welcome. Thank you.
Second.
Okay, all in favor say aye.
Aye.
Aye. Okay. Good deal.
Dr. Bobrowski, this is Nicole.
Yes.
If I could ask really quickly, I apologize for interrupting. For that report request, will that be supplied by DMS for each of the payers, or will DMS only provide fee for service and you would like the same information from each of the payers?
So Nicole, we'll take that back and we'll reach out to you all if we feel like we can't provide it for the entire, because I think we could probably provide it for fee for service and MCO, but
Okay.
If we're having some challenges, we'll reach out to you all and because I know they want to see it across both spaces.
Thank you.
Yeah, thank you.
Yeah, Nicole, thank you for that question. It does clarify. I guess in our minds, we were thinking about all the MCOs and fee for service. So, but thank you for clarifying that.
If I can interrupt just a second, Dr. Bobrowski.
Yes.
Deputy Commissioner Cecil needs to get off at 3:30. So if you needed something else from her, you might want to catch her in the next 6 minutes.
Okay. Well,
Yes,
I've got one other question.
Thank you, Shirley.
One other question would be, like, how many submitted claims, I guess, per that category, and I don't know other than, and I know with some of our other conversations with Commissioner Lee, we've have talked about maybe doing some kind of a survey of who is actually treating members. Are you accepting new members? What degree have you limited your practice? And I'm not really good at formatting that type of survey, but I know we have talked about it in other meetings.
Dr. Bobrowski, this is
Yes.
Angie Parker with Medicaid, and I know Dr. McKee is on the line, and I'm just glad you brought that up because we have been working on a survey. And Dr. McKee, if you want to talk about it.
Yes, thank you, Angie. I appreciate it very much. It's Julie McKee. For people who don't know, I'm the State Dental Director over in the Department for Public Health. And with me today on the call is Lindsay Metters, and she's our epidemiologist in the oral health program. And we are working with Medicaid to develop a survey to help them out to report to Insured Kids Now. But we thought we'd add some more questions to see exactly what was going on. Now, there's going to be some limitations to this survey because we can't force everybody to do the survey. So it's going to be a true sample, hopefully a good one, of providers throughout the state. And we're working hard to keep that as short as possible. So hopefully the dentist will receive it and fill it out rather than giving it to their office manager. And we're working with a survey design that actually helps out the taker of the survey, that if it's a no, it'll take them to the next question. But if it's yes, it might take them to another question to fill that out. So it will go to all licensees with the Kentucky Board of Dentistry, probably under my name. So maybe they'll see it and delete it, or hopefully they'll open it. We're going to ask them what kind of dentistry they practice. We're going to really get down to hopefully the nitty gritty of exactly where they practice. I was frankly disappointed to hear about the 16-hour thing being the full time that they gather information, because there are a lot of dentists that spend a lot of time at different locations. So we're going to ask them how many different locations they have, where those are exactly, so we can map out how many hours a week do they spend in that location, so we can truly map the network of Medicaid providers around. When are they open? How many patients they see on a particular time frame. I think we're thinking about a week. Do you accept Medicaid? Because it's going to everybody. Yes or no? So if you do, which ones do you accept? Click, 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 click. What ranges do you see? Because a lot of Medicaid providers will limit who they see as far as the ages go. And this is even general dentists, just not pediatric dentists. We want to know where those gaps are. Are you currently accepting new Medicaid patients? We want to know that. That is one of the core questions that the Department for Medicaid Services wants to know. Then we get into the juicy part of what challenges do you face to provide care to Medicaid patients? And we've got low reimbursement rates, no time available because you're busy with other patients. Medicaid patients have barriers coming to my office. We were talking about social determinants of health, and that gets that question. I'm short-staffed right now. Societal barriers of patients that is perceived or real of the provider. Broken appointment problems and burdensome paperwork, and then we'll probably have another, the and other box that you can fill in the blank. We're going to ask them if they've got a website that will help us out a little bit. And we also have a catch-all question at the end that says, what have we missed that you want us to tell us about? Now, that is not a good design of a question, but that's why Lindsay's into play. She's an expert on survey design. We're working with an intern to get this done, and we're just about ready to send it out. Now, what I'd like to do is get your all's feedback right now, but I would also like to send the survey in test pilot mode to the dentist on this call, just to get some feedback. Is it difficult to understand? Was it too short? Was it too long? What are we leaving out? That type of thing. Before we want to test drive it a little bit before we send it out to the gazillions of Kentucky dental licensees.
Well,
any
you
questions?
Can send me one. I'll fill it out.
Thank you. You're on my list, sir.
Okay.
Yeah, I mean, you can send it to me. I've got about 70 Medicaid providers that I'm over. So,
okay, I will send it to you, and you can, if you want to, you can send it out to them as a test drive. The thing is the bigger test population we get, the better the end product is going to be.
Yeah, I'll send it out to.
Thank you.
Some.
Happy for you to send it to me as well.
Well,
I do not have 70, but I'm happy to fill one out.
Well, thank you, because you were going to get one anyway.
Joe, it's not always the joy that it may seem.
Right.
Yeah, down here where I'm, it's just me down here. So it, bless your heart, Phil. I have enough trouble keeping myself going that I can't imagine being over 70. But okay, Anything else to report on, Dr. McKee?
No, I don't have anything right now. People know how to reach me, believe me, and they're welcome to reach me. If you don't know how to reach me, just ask Garth, ask Jerry Cottle, ask Angie Parker, ask Lisa Lee. They all know exactly where I live.
Well, I'll go ahead, and I've made a note here too. I'll add that to our next agenda to discuss the survey. And
Okay.
see what kind of status we're at, and if you've had results and stuff like that. So I'll put that on next time's agenda.
I appreciate that. Thank you.
And thank you for you're just always a step ahead of us, and that's so nice. It's good.
I don't know about that.
This will
right,
help Medicaid out a lot. This will help Medicaid out a lot as well. I mean, and I want to clarify the network adequacy aspect of this in the 16 hours. Because we've looked at that and trying to make sure, and it's not just dentists, it's all provider types, ensuring that our members do have adequate access to care. And if a physician of any type is only in the office 8 hours in one place a week or a month, that's not network adequacy. So that's why we kind of put it at 16 hours, even though technically speaking, 16 hours in a month at one location really isn't, but it's a little bit better than 1 day a month or 1 day a week. So that's why we're looking at it that way. And that's why it was changed this year. I just wanted to clarify that for everybody and let them know how that came to be. Any questions on that?
I do have a question on determination of network adequacy, not so much on the point you just made, but in general, and still on looking at the numbers that we received today. I'm wondering how it's determined what is an adequate network based on numbers per GP and per specialist. Doing my quick and dirty math, we've moved in GPs from 1 in 950,000 to 1 to 1,101. Factoring in the presumptive, it's still moved up to 1 to 1,020. Oral surgery has gone from 1 to 15,783 to 1 in 25,000. Also big jumps in pediatric dentistry from 1 in 20,000 and change to 1 in 23,000 and change. Ortho 1 to 19,000 to 1 to almost 25,000. So these are how are we determining what is an adequate network? And beyond that, one thing that we've discussed in these meetings before is a lot of these, especially like what Phil was talking about, but also what our specialties even more so are group practices. And so we're actually one practice will have multiple providers, and that may not necessarily mean that it's a 1-to-1 ratio there. So my long-winded question is, how are we determining what is an adequate network number to number? And my hope is to help have a better understanding of what the true network is.
And that's where we're trying to get at too. I mean, that's been a challenge for Medicaid and understanding what the true network truly is. And it's been a challenge since I've been here, and I think it's been a challenge forever. And that's why we were looking at the hours involved, in a particular area. But in general terms, as far as your question, and specialists, they have to be located within 50 minutes or 50 miles from their member. That's how that network or geo access is what they call it is determined. So if if I'm living in, let's see, Ashland, I should have a dentist within or an oral surgeon within 50 minutes or 50 miles from where I live. And that's how they determine adequacy, if there's someone in that area that would address adequacy.
I think that is a challenge because within 50 miles, there can be, especially in rural Kentucky, you might be within 50 miles and there's clear access to care issues on people's ability to travel the 50 miles. But also you look at, let's take, for instance, Prestonsburg. There's one pediatric dentist there, and the closest to him is Pikeville or Hazard. So from Hazard to Pikeville, there are, excuse me, I'm from Southeast Kentucky. I need to say it correctly. From Hazard to Pikeville, there are only 3 people covering all of that population. So when I break down these numbers and I come up with a pediatric dentist 1 to 22,000 people, it's actually a lot worse than that, because in that population, there are only 3 in that area. There might be 15 in a more urban section, which does have a higher population, but I still believe that we have even worse access to care numbers based on these more rural single doctor practices.
And you're exactly right. I don't, how you get dentists or oral surgeons in those areas. That's the challenge as well. They may be the only pediatric dentist within 3 hours, probably in the area that you're talking about, whether or not it's Knoxville or UK. So it is a challenge. I think it might be looked at as far as pediatric dentists, as long as there's a dentist that will treat them and that not necessarily identified as pediatric. So, but at this point, looking at 50 minutes and 50 miles, how each area can potentially hire or drive more providers to certain areas is an access issue for sure, and we know in Eastern Kentucky. And it's not just Medicaid; it's for all Kentuckians.
It sure is, and we have had this conversation before, and I hate to beat a dead horse, but what we're doing is we're taxing the individuals who are actually in those areas, trying to make it work. And as we see numbers dropping off, we're seeing numbers drop off because of the challenge of continuing to do it post-COVID, but also just as everything cost to treat increases, and we're not seeing a change in reimbursement. We're seeing more difficulties as far as issues with the system itself. And I know all the MCOs are working hard, and I appreciate the work that they're doing to improve that. But at the end of the day, if we keep making this harder to do for equal or what is effectively less reimbursement because costs are increasing, we're only going to see more numbers dropping off. That is a big change in oral surgeons. We're only going to see more of that, which is going to tax that system more, which is only going to make the folks out there that are actually doing it less likely to do it. And it's going to make that appointment time significantly higher. And I don't think we have you can't blame the provider who is slammed and can't get someone in for 5 months because they're barely keeping their head above water. We've got to get more practitioners. And the only way to do that is to reduce the barriers to keeping people from doing it. And those are a lot of monetary things. And I don't know how to get there, but that's huge.
Charlie, for the record, Dr. John Gray is on the call. I think he can hear, but he's having trouble with his getting his voice activated. I didn't know, Charlie, if you might could help him on that. But another topic that is in line with that, and we brought this up a little bit at the last TAC meeting was, and it was mentioned today about how the registered nurses are being hired out from underneath the oral surgeon's offices. It happens to the GP office too, where because of I guess there looks like there's numbers have increased in providers, but either everybody's just so busy they can't get in certain offices, and other offices are just getting slammed, and I mean, it's just like we kind of hear the common thing down here. It's just like we can't work fast enough or hard enough, and our staff is just, they just feel like they're worked to death. Seeing patients at such a rapid pace and trying to turn over and clean and sterilize and get rooms ready. And I know there's a big demand for assistants and hygienists. So, staffing is still a problem, even in the dental arena, in terms of we want to see patients, but sometimes we don't have the staff available to help us. It's like the oral surgeons not having the registered nurses to help them with. So the staffing is an issue. Now, Dr. McKee, Dr. Gray did send me a note here that, and I'll add to his note, was if you've got an intern or extern, he said, well, you might even be able to just, along with the survey, just to call the oral surgeon's office and just see how long it takes to get in, just for a routine evaluation and then follow up for extractions. That's an idea that Dr. John sent in, was just how long does it take to get in at the various oral surgery offices in the state.
That's a good idea. We're going to be losing our intern soon because his college starts up quickly, but that doesn't mean we can't do it. Okay. With 66 or how many ever, I've got it written down here.
Yeah, 66, 67
66,
back in 2000.
I think we can make that call. Everything's skewed, and because I do get calls, I cannot get in, and we do send them to their MCOs. But the nasty fact is that if I call as what we call a secret shopper, and I have third-party insurance, I can get in a whole lot quicker, even with an oral surgeon's office, than I can if I present as a Medicaid patient.
Right.
Just a couple things, Dr. Grabowski. This is Charlotte. Dr. Rich had given me Dr. Gray's phone number, and I have him unmuted, so I'd like to see if he says anything, if we can hear him.
Okay.
And then also, do you know if the Kentucky Dental Association has a list of active dentists in Kentucky that are licensed?
They do, and probably it might be even quicker to request that list from the Kentucky Board of Dentistry. With it being another government agency,
that list is not hard to come by.
Yes. Okay.
I was just thinking maybe that would be an option if we gave that list to MCOs to try to reach out to them to see if they would become participating with the MCOs.
I'll tell you what I can do is I'll mention that to the office at the KDA office, and see if, or Dr. McKee, when you get ready to send that out, either let me know or go ahead and call Mr. Whitehouse at the KDA office and see if the KDA can advertise and put a plug in to the dentist to fill this out. Of course, most of our information goes out to KDA members. And that doesn't reach every dentist in the state. So the list may be also better to get the list from the Kentucky Board of Dentistry.
I have the list. And
Okay.
they give it to me for public health reasons, and this is a public health reason.
That's right.
Mm-hmm.
Garth, this is John Gray. Can you read me now?
We got you now, John.
Hey, there you go. The reason that you can get an appointment if you have private pay or some other type of insurance is because that if we don't leave private pay spots open, at least some, were so overrun with Medicaid that we could never get a private pay patient in.
Oh, I understand the reason why.
And you have to have some mix when you're getting a third of your fee, which doesn't cover overhead. You have to have some mix of private pay in order to keep the doors open. So we're forced to leave a few spots open.
I understand that, but it still delays care. But golly, yeah, it's a business. You got to make that mix work. And, and also it depends on how long that wait is. Is it 7 days? Is it 43 days?
Or 60 days or more.
Or more, yes.
Yeah.
I think we have to be careful. I think we have to be careful calling it a nasty fact too, because there's certainly a financial reason why that is, and the importance of still being able to have access to care to all patients. We also have to factor in things such as no-show rates and aspects such as that. Because if you overfill your schedule without planning for any patients other than Medicaid patients, then when you have a 30% no-show rate for a myriad of reasons, then you also are delaying care to the patients that are showing. So I think John's interjection and mine as well is more to the phraseology of a nasty fact, because I think we need to be careful with the people that are out there that are actually busting their hump and doing this at times at a loss for this population, to consider their practice as a nasty fact.
And I apologize for that. It's just that my job description is access. So I fully apologize for that. I just wanted to make the point that it does exist, and I understand the business aspect.
No apology needed, but there's also access to all patients, and I think the folks on this call pride themselves in providing the same quality of care and access to all patients, but factoring things in like no-show rates also are important, because we have, as we all know, the people that are seeing this population are at their limit or beyond with the number of patients seen in a day. And so it's a challenge, and it's a challenge to make sure that we have a schedule that allows us to see all patients.
Dr. Bobrowski, this is Nicole. If I can share with everyone that one of our contractual requirements from a reporting perspective is to conduct quarterly access to care surveys. Our access to care surveys are focusing on routine and urgent appointments. We report those results out to our MCO partners on a quarterly basis, and then provide an annual summary. So by the end of the year, the goal is that, or the target is that we would have surveyed 100% of the network. So we do a quarter of the network each quarter. And then in addition to doing the access to care surveys, we also do an after-hour survey to ensure that they have after-hour instructions for patients, and we report on that also. So just a FYI that is of information that is available, and it is something we're required to report as part of our Kentucky reporting packages.
Oh, yes, thank you very much. I know, I think it was two Wednesdays ago, I had 8 Medicaid folks scheduled that did not show up and did not call for their appointments. And boy, that you miss 8 patients of time, and that really knocks a hole into your plan schedule. And then I think in terms of access to care, those 8 people that didn't show up, they knocked 8 people out of getting other stuff done. So, we really try to stress this to patients down here on our end of it, that if you can't come, just please give us a call, unless it's a big emergency. But we still have them every day. And I know that's one of the access to care problems. It's like sometimes patients just do it to themselves. They shoot themselves in the foot, and then they do this office that way, 3 or 4 appointments. They'll do another office 3 or 4 or 5 appointments. And I looked at one lady here yesterday, and well, she's already missed 5 appointments, and yet well, if she calls, we'll try to see her, but then she'll, somebody yesterday missed the appointment for a toothache. Well, all right, don't call me at 2 o'clock in the morning with your toothache. I'm sorry, you had your chance. But that's just the way I am. But I'm going to move on to old business.
Oh, sorry. This
Somebody say.
Kind of on that note with the broken appointment or cancellations for that matter. I guess just kind of questioning. I know that we do cover and have a small reimbursement for those services so that providers can submit claims and we can kind of collect data on the members that are potentially missing appointments or trending with cancellations and things of that nature. Do you all utilize that? And I only ask because we do capture it. I feel that a lot of providers don't use this as much as I think is actually happening. Sometimes the data doesn't always represent, and I understand that there's administrative challenges with filing a claim or something like that. I just didn't know if there was any other way that you all track information and share it with us.
Is this Christina again? The voice cut out on me.
Yes, sir. This is Christina from DentaQuest.
Okay. Yes, thank you. We'll, and I guess that's one of the things that I guess you will have to stress to your providers that they have that availability to them to be able to do that. I'm going to go on just a little bit here with, is there any status report on the MCO contracts with the judge's ruling?
No, sir. This is Lee Guy. There is no status report. It's still a pending lawsuit. It's on appeal. So we don't have anything to offer. Sorry. Okay,
that's fine. I did get a phone call from a dentist it's still under the old business, but he was having some retro termination problems with patients showing up as not eligible for treatment. And he said, I've been working on this for over a year. He said, I've got proof that they were eligible to be there that day. But he's not getting any response, not getting any resolution. And to matter of fact, I forgot to write down which MCO he was working with. So all I can say is, and I know a lot of you do all you can to help the various providers, and but I just know that sometimes that retro termination problem can be a problem for some of the providers out there. Is there any other old business? Hearing none, I'm going to move on for new business. We got just a few minutes here to finish up, and we're just about done. Is there any motions that we need to bring to the MAC? One thing I was thinking about was what we had talked about before was, the social determinants of health, and that the dental TAC would still like to engage the other TACs, to continue looking at that avenue. I do want to bring that up. It really won't be so much of a motion other than an FYI.
Yeah, Dr. Borowski, unfortunately, you all don't have a quorum to pass motions. According to the open meetings law, you have to be on a video in order to be able to count toward the quorum. And is Dr. Petrie on video. I mean, you're more than welcome to talk to the MAC about these other TACs, but you can't make a formal recommendation from this TAC.
Okay.
Well, Darth, if you can get on video, we would have a quorum because both Phil and I are on.
He's got off. Phil got off.
Okay. I'm still here.
Oh, you're still there?
Yes, ma'am.
Well,
Yep.
I looked at through there because you disappeared off of my screen. Huh.
I'm sorry. I'm still sitting right here.
Well, that's strange because I wasn't seeing you in the list. I'm sorry.
No, you're all right. You see me now?
I do see you now.
Good deal.
Do you have me? This is Garth. Do you have me on video?
I do not see you on video.
See, I was on there a while ago because I saw it when I was talking there. But then
Yeah,
I haven't seen it.
I have seen Dr. Bobrowski on here.
Yes, I know.
Okay.
I'm on there, but I'm not seeing him on video now, unfortunately. Like I said, Dr. Bobrowski, you're welcome to say that at the back, that, you know, about what you were talking about as far as the other committees. It just can't be an actual motion from the TAC.
I'm not sure we need to make an actual motion anyway, Garth. I mean, I think it's something you can just let them know that we've discussed, you know, at the Dental TAC, and that we would support, you know, any, you know, helping in any way we can to you know, work with folks to see the impact of social determinants of health. I mean, I don't think we necessarily have to make a recommendation to the MAC. It's just my opinion.
Okay. That's kind of what I'd planned. I thought we could just do it as that we have discussed this, and not really a motion, but we're willing to work with other folks. I just wanted to remind folks at the KDA is having their annual meeting not tomorrow, the next Saturday, the 21st, at the Galt House in Louisville, Kentucky. It's going to be at 9 a.m. Eastern time. We're going to have a Medicaid forum, and all the MCOs have been asked to be representative and have been asked to have a participating role in that. And from what I understand, too, Commissioner Lee plans to be there. So it's the Saturday, the 21st at 9 o'clock Eastern time at the Galt House. If you're interested and I wrote down the room number, but if anybody needs that, I can get you the room number, or at the registration desk, they'll have that there too. And the other information, Dr. Brandon Taylor, he's at a clinic there in Owensboro, and he is no longer going to be a TAC member. So you other TAC members, if you know of someone that would be interested in becoming a member on the TAC, that we do meet quarterly, either by Zoom or in person. Maybe when this virus is over with, we'll get back together. But we meet quarterly, but I just want to let everybody know that's why Dr. Taylor is not on the call today. And are there any other comments, questions? Hearing none, our next meeting is Friday, November the 12th at 2 o'clock Eastern time. And hopefully I will get my video portion worked out or something. We'll try to get our technology back up to par. It was working fine last meeting, and it looked like it was going to work fine today, but I apologize if it's on my end. We'll do what we can here.
Hey, Garth, can I make a comment?
Yes.
If you or Charlie or somebody could send out that Zoom link off the CHFS website, it's hard to find that on the website. I actually had to go into an old meeting to find the meeting list for the current meeting and click on that link to get me to here. So when you send out the minutes for this meeting, it might be good to just put the link, you know, in the same email, so we can just click right on the link and come right to this meeting.
All right.
Thank you.
Charlie, as a point of order, where Garth was on the Zoom meeting by video when our only motions that we have gone through so far were passed, will that quorum be considered for those, or this
Yes,
whole meeting? Okay. All right.
yes. The meetings, the approval of the minutes is fine because he was on at that point in time. And, you know,
But
I'm
Charlie,
not,
I'm still on.
well, I know, but I'm not seeing your video. And I promise, guys, I'm not an open meetings stickler I'm not going to report anybody for following open meeting laws. But anybody on this call can easily report us and we'd all be in trouble. And I'd probably end up being in the most trouble because I allowed it to happen. To me, it doesn't matter.
We don't want to get you in trouble.
My goal is to retire without getting in trouble. So.
Well, we'll do what we can to not get you in trouble. We appreciate your efforts and all that you do for us. And I know some of this technology can be tricky. And I mean, it's not even cloudy, raining or nothing down here where I'm at. It's not a weather problem. It may be on my end. I don't know. It's like I don't know why you said something about getting a lot of background noise. I'm just in here in a single room by myself in the office, and I mean, there's nothing humming or nothing really even on. I don't know what would be making that noise.
I think that was just maybe cell phone interference, not even something that, because I know when I'm talking on my cell phone, sometimes whoever I'm talking to will say, "You're not coming through clear to me," and I don't hear a thing on my end. But when
Yeah.
Hey, Garth. Hey, Garth. Are we wrapped up? I hate to say it. I got another 4 o'clock call I have to be on.
Yes, we will adjourn this meeting. I didn't hear any other comments, so this meeting will be adjourned. And I've got a patient to see right now too. So
thank you all. Appreciate it.
Thank you.
Thanks, everybody.
Thank you all. Have a good weekend.
Charlie, John Gray, before you hang up, are you still there?
Yes, I am.
I've tried on 3 different devices using the join Zoom meeting with the password 1SF capital MSL and the ID 599250, and it will not log in from where I am. I don't know why.
And see, you shouldn't even have to use the password or anything because nobody else has.
I mean, I get it, but I've got an iPad. I got an iPad, and I couldn't get it to. Number one, I couldn't have voice, and I never did get video.
Yeah, it's strange because I've never had it set up to where anybody had to do. Actually, it provides me a password, but I don't set the meetings up to where you have to enter the password. So usually when you click on that Zoom link, it should take you right in. And I actually joined from the Zoom link on the website, just so I know that it's that it is working. And
we'll put the website on the next one. If you'll put the website on there, and maybe we'll go to the website and try doing it that way. Because I'm not doing it that way, and it's obviously I'm not doing it right. So
okay,
I'll
put that on. Okay.
Thanks a lot. Have a good day.
You too. Thank you.
Bye-bye.